All right, it's 1 o'clock Eastern time in the United States, and it's all over the map throughout the world. So I wanted to welcome you. My name's Eric Alexander. I'm the executive director of the Brigham Education Institute. I'm vice president for education here at the Brigham Women's Hospital. And we've had just a great deal of fun with Shubha Ramani's leadership, putting together this entity that we refer to as the Global Med Ed Café, just kind of a facility to discuss some of the kind of ongoing and current topics in medical education and really make it an informal connection and community for all of us throughout the world. So this is our third one. It's great to see the interest and the continued ability for everyone to join. We're trying to stagger times because I know it's so hard across the globe. With this, I'm going to turn it over to Dr. Ramani, who will introduce also our colleague, Dr. Thampy, and appreciation so much for him joining us from the University of Manchester. Shubha?
Thank you, Eric. It gives me absolutely great pleasure to introduce Harish, Thampy. And in fact, Thampy in our language from southern India means little brother. And that's pretty much how I feel about Harish. We have known each other now for 10 years or so. We have presented several workshops together, and we've written a lot of papers together. So very briefly, I can't go over all of Harish's accomplishments, but I'll tell you he's a general practitioner clinically and professor of medical education in the Faculty of Biology, Medicine and Health at the University of Manchester. In fact, maybe the largest university medical school in all of the United Kingdom. And Faculty of Biology, Medicine and Health for us is medical school. He serves as the director of assessments, and particularly OSCE is his area of expertise, for the MBCHP program, which is our MD program in North America, and is also a lead for the postgrad certificate in medical and healthcare education program. So with that, we can stop sharing, and I think Harish wants to share his own slides. So here is a format for today, and this is a format, so our group, we're now termed Mentors Across Borders, and Elizabeth is there. She's one of our core members. Hi, Elizabeth from New York, whom I've known for almost 20 years. So anyway, so this is a format we've really found very successful. So we look at it as opening the doors and facilitating global conversations. We don't look at ourselves as experts trying to smush knowledge into people's brains. This is conversation, and along with the dynamic conversations, we all learn so much more. So I will turn it over to Harish. He will present briefly. He'll give us an overview of clinical reasoning. That's the topic today. Then we'll go into the small group activity, which is the breakout groups, and you all have on your handout the questions. So groups 1 and 2 will discuss the first question, and groups 3 and 4 will talk about the second question. And when we come back, your group reporters will report, and Harish will give us his comments and his thoughts on our own strategies that we come up with. We will then end with a brief summary, and there will be plenty of time for interaction. And Christina is an amazing chat moderator, so she will bring, not only will she respond to your questions then and there, she will also bring the key questions to a more verbal discussion. With that, over to Harish. Thank you.
Thank you, Shubha. That's a very kind introduction, a very impressive introduction, and I hope I can live up to that introduction in this session. So, as Shubha said, I spent a lot of my time in Manchester looking at clinical reasoning, very much as it applies at both the OSCE level and workplace-based assessments in undergraduate education. And the focus of today isn't really for me to kind of profess any sort of expertise in this area, but a chance for us to learn from each other and to gain from your own experience and skills in this topic. So a very brief few-minute presentation, just to give some context before we move on to the task. So I want to use this session to explore collectively what we mean by clinical reasoning. I'm sure you all understand what is meant by the term, but to understand the importance of then assessing that skill within medical education. Clearly, assessing the skill is a challenge, and we want to explore some of those challenges today. Looking at those challenges in both the OSCE shows how level and the workplace does level of Miller's pyramid. but crucially then move on and spend most of the time discussing, sharing and suggesting strategies to then address those issues. So there's a whole variety of definitions I could have picked to look at what clinical reasoning means. And I like this one from Higgs, which very simply says it's the thinking and decision-making processes associated with clinical practice, that whole ability to think like a clinician. And there's lots of theories and frameworks which underpin the clinical reasoning literature. And the one that's kind of most widely accepted is dual process theory, which I'm sure many of you will be very familiar with, which suggests that we think in two main ways. So type 1 or system 1 thinking is very fast, very quick, uses pattern recognition. So as Shubha said, I'm a GP. My practice is right next door to Manchester Airport. Someone comes off a long haul flight, comes and sees me with a big red hot swollen leg, very little thinking going on. I'm going to presume that they have a DVT. Now that is fine if we have lots of patterns and experience to base those judgments from. The problem with type 1 thinking, though, is it's potentially more prone to error. System 2 thinking, on the other hand, analytical thinking, is much more slower, deliberate. And often as a general practitioner, I get patients coming to me with rather vague symptoms. And through a very analytical approach, I will be working through a series of differential diagnoses in my mind, asking questions to help rule in or rule out potential diagnoses as I narrow that differential down. So clearly it takes much more time. And we know from the literature that we toggle between these two approaches, often unconsciously, throughout our clinical working workload. And so with that context, why do we want to assess and teach clinical ability in clinical reasoning? I'm sure you recognize some of these things. So students who are very patient-centered, but they clarify to no real purpose. They're not thinking through the presentation that they are facing. We often have students who just ask the same series of questions of every single patient, regardless of what they say. So what they're very good at doing occasionally is learning the sequence and list of questions, but you can tell they're not thinking through what's going on. They're not understanding what the last bit of data means. How is that data narrowing down this differential diagnosis? Learners who, again, very quickly latch onto diagnoses, and so they don't consider all of the information. And there's the whole literature around cognitive biases, which, to be fair, is a bit controversial as to the role they play and how much we can do about it. We often have students who are asking questions inappropriate for the patient demographic in front of them, again, because they are very good at learning a preset list of questions rather than really logically working through things in their mind. And students who struggle to focus their examination into relevant steps. And so I want to kind of, with that kind of context of challenges, look at where we want to move to. So this is just my kind of perspective on the OSCEs. What I tell my students and what I tell my colleagues in Manchester, what I want is our learners to be this clinician on the left, to approach any patient consultation very analytically with a range of differentials in mind and really demonstrating clinical reasoning, very much system 2 thinking, working through logically a series of differentials to narrow them down through the questions they ask. But often what we get is the parrot or the robot. So the parrot who just parrots off a whole series of questions that they have learned, irregardless of what they're being told by the patient. And perhaps more annoyingly as an examiner is the robot who does the same thing as the parrot, but very mechanistically, and you just see them just working through this pre-rehearsed checklist. And that may be a fault of how we design OSCEs. I put this picture up on the right, which is a picture I was shown when I was doing my cardiology placement as a medical student. It took me a while to find it again for these presentations. And it's a picture, as I'm sure you can guess, of someone who is in the midst of having an acute coronary syndrome, describing all the key typical features you see. So as an elderly gentleman, he's had a heavy meal in a restaurant, it's a cold day, he's just walked up a flight of stairs, so there's some exertion going on, clutching the left side of his chest with pain going down his left arm. And how often do we see patients presenting with all of the textbook type description symptoms? As a GP, I don't. I see patients presenting with a variety of vague symptoms. They may have symptoms unrelated to the presenting situation. But we often, at least historically in Manchester, had OSCE stations that were very barn door. And therefore, all we're assessing is students' ability to recognise patterns, system one thinking, which, whilst it has its place, isn't really promoting their more analytical system two thinking. And therefore, how we design our OSCEs will impact on how they learn. And then moving lastly to the workplace setting, there's really two main modalities, isn't there, in terms of trying to evaluate our postgraduate learners' reasoning ability. And that may be through direct observation of their clinical encounters, or it may be through post-encounter discussions, either through case presentations, case discussions, chart-stimulated recall. And I'm not going to say much more at this point, because I want to just, with that context, get you in the groups to start to think about the clinical reasoning pathway and how we better use OSCEs and workplace-based assessments to assess these skills amongst our learners. And this is a very brief schematic of the clinical reasoning process, where at the beginning, our learner is going to gather information and generate those hypotheses. And that information gathering may be through history taking, it may be through physical examination, hopefully both. And then from that, generating the key problems and identifying the key problems and being able to represent them succinctly, through to then generating a differential diagnosis, and crucially justifying and prioritizing that differential diagnosis to then make management plans, and alongside them being able to then reflect upon their own clinical reasoning approach that they took, that metacognition. Can they understand why they asked the questions they did? What possible biases may they have been swayed by? So with that schematic, as Shubha mentioned, we're going to break you up into these breakout rooms, with the first two rooms really focusing on the OSCEs. How could we better use the OSCEs to incorporate assessment of clinical reasoning? And we just want you to come up with two key strategies in these two rooms. And in the second two rooms, doing the same within the clinical workplace, two efficient approaches, but also thinking around one thing you would do differently at the various levels of undergraduate, student, resident, and fellow.
It looks like we're all back in the main room. So group one, reporter.
That's me, yes. Hi. So we had a wonderful discussion with Ariel from Dana-Farber here, Alexis from France, Ed, and myself. We tried to address the question, which we think we wrote down correctly. List two strategies for incorporating assessment of clinical reasoning. We started our discussion with an exploration of some of the challenges, and one of the key ones is OSCEs require some standardization, but what we're looking for often we think is around adaptation. We came up with actually 5 strategies. I'll give you the top 3. So one was the idea that the current rubric for doing assessment of OSCEs could be enriched to include elements that are, one, unique to the situation, and then other ways that we measure the thought process and the way that students pick up on things. One of the second top ideas was this concept that we could really enrich the OSCE, and 2 particular ways were, one is enriching some of the information as it comes in a case. So we introduce a pause moment where new information actually changes the diagnosis, and we expect them to use clinical reasoning to then change something. The other one was to like with the patients, encourage them to say, "What made you think that?" as a standard prompt to encourage people to think out loud. I think that our this idea of modeling thinking out loud was really important. And then I think that our big, one of our ideas about a missed opportunity was this idea of rethinking OSCEs, and how could every patient encounter be an OSCE, which is probably that it would happen retrospectively, but there's lots of opportunities in training where if we think back on how a person evaluated or interacted in the situation, we could think about it in an OSCE framework. Team, did I miss anything?
Thanks, Narath. So for group 2, I will just report our strategies, and the group can add if I've missed something. And then after that, we'll just have a very brief moment where Harish can respond to the OSCE group's strategies before we move on to the workplace. So as a group, we decided that this checklist model for OSCE assessment is not very conducive to clinical reasoning. And instead, what we need to think about is post-encounter probes, which include the questions about a lot of why questions And one thing Francesco talked about, which he and Eric have discussed before, is what are you doing? Why are you doing it? And what would you do next? So that would assess clinical reasoning. And the other strategy that the group came up with is have somebody, a demonstrator, do the exam or take the history and purposely make some mistakes, while the student, the learner group, is basically observing and then coming back to what were the errors, why do they think those were the errors, and what are the suggestions to address those errors. And finally, video and group reflection and debriefing was another strategy that our group came up with. So group 2, would you like to add anything before we ask Harish to comment?
Seemed quite comprehensive.
Okay.
Maybe the issue of culture. We also talked about how in certain countries and certain regions of the world, some discussion of mistakes can be done more easily than in others.
Harish, we're all agog.
Thanks, Shubha. I've just got one slide to share, and as I'm doing so, I just want to highlight, when I started to look at this some years ago in the literature, there's actually very little written specifically around OSCEs and how they can be best used to assess reasoning. It's all implied. You read multiple texts going back to the 70s that they assess reasoning, but very little specific detail given. And so a large part of what I've written here has come from synthesizing best practice from our own institution and elsewhere. And I think you've covered a lot of this already in the feedback. So I've put it as part of station design and marking. So station design, really designing things around whole tasks rather than arbitrarily kind of creating part task stations that don't resemble real clinical scenarios. As per my acute coronary syndrome picture I showed you before, trying to avoid creating scenarios that are simply pathonomic presentations, but design the scenarios such that there are a range of plausible differentials at the end of taking that history, as opposed to a single diagnosis. I mentioned before about this hypothesis or presentation-driven physical examination. There is quite a lot of literature around the benefit that brings in terms of assessing examination reasoning skills. And we use a lot of integrated data interpretation as part of the station, a bit like what we were hearing before of adding in new data or facts during the station as it runs. And then from a marking perspective, really moving away from checklists, as we heard Shubha say, moving more towards domain scale marking. And then this focus on the post-encounter exploration, either using documentation, which is very much common across in the States. I understand we use very little post-encounter forms in the UK setting. I think we need to do much more in terms of that. And as we heard from Shubha just there, really using the post-encounter questions from the examiner to really probe that justification, prioritization, and transference of reasoning from the learner. So I'll stop there, Shubha, and we'll move on, I think, to workplace and clinical settings.
Yes, thank you, Harish. So group 3, was it you?
Yeah, I'm the reporter for that one. And we were tasked with the question of how to make something more efficient in terms of assessing clinical reasoning. And we went in some very interesting directions. Ultimately, we came forth with the idea that the goal of making something efficient is first to begin communication, right? That there has to be good dialogue between the learner and the teacher for you to begin that process. We had a very interesting discussion of whether ultimately the ability to assess reasoning had to really be at the level of one-on-one teacher to learner. And that's an interesting question to come back to for Harish, which is can a group be assessed, even a small group, for its reasoning prowess, or ultimately do you just end up with the one person who knows it and the 3 who aren't quite there yet? And then we went and certainly kind of came into the efficiency question by acknowledging there are already models out there like the 1-minute preceptor or the RHYME model to push people to kind of understand that next level or to activate the process. And those can be very useful ways to move it efficiently. And the last question, I believe, was what one thing would we do different if in relation to students, residents, fellows? And I think we kind of all agreed that the first thing we do is try and break them up, that at least in the US on inpatient training wards, so often they're all kind of lumped together. and you create a pretty inefficient scenario where you're assessing reasoning or teaching and learning either over someone's head or far under someone else's head. And so maybe it is much more on that individual basis. So I'll stop there.
Thanks, Harish. Then we'll first, before, I think it's your group, isn't it? Group 4?
Yeah.
Okay, and then you can answer your own questions. Okay, it's all over to you.
That's fine. So I'll summarize for group 4. So when we started to explore the strategies within the clinical environment, they all tended to focus initially around post-encounter examples of case discussions and using a variety of questioning styles. So we explored snaps, we mentioned micro skills as ways of unpicking the learner's reasoning approach. I kind of prompted the group to think about beyond just the post-encounter and the power that live observation can bring, and what sorts of approaches can we use in the live encounter. And we were sharing examples of stop-start, where we use a lot in Manchester, which you need patients very much prepped and prepared to be interrupted as the learner takes the history from them. But asking the learner as they take this history to justify their differential as the history is unfolding live in front of you. And clearly that needs a very careful setup for it to work well. We also explored feedback, as no assessment or evaluation is useful without providing good feedback. And we discussed the sorts of feedback we would be providing learners after assessing their reasoning skills. And we discussed some of the potential assessing reasoning tools that exist out there, which are, one I suggested was the assessment of reasoning tool from the Society for Improving Diagnosis in Medicine. And then in terms of strategies that differ between student, resident and fellow, we explored the increasing complexity is very important. So whilst, and I don't want people to think that learning patterns isn't important, but that patient with the acute coronary syndrome presentation would be suitable for a very junior learner, creating more complex, nuanced clinical scenarios for your more senior learners. Hopefully that captures the discussion from our group. Dr. Park in our group did mention, Eric, this comment you made around moving beyond the individual learner, and because reasoning doesn't happen on an individual basis. It happens within teams, it happens within environments, there's system factors and environmental factors at play. So I think it's a very good point. We need to move beyond assessing the learner in isolation. And so we've done some stuff in Manchester with interprofessional scenarios where we have had pharmacy students and medical students together, where we run scenarios and assess kind of team-based reasoning from everyone involved.
Thank you.
Thank you, Harish. Thank you very much. So we covered clinical reasoning. How do we demonstrate and assess clinical reasoning in the OSCE setting as well as in the workplace setting? So what I'm going to do is we are about 9 minutes to go. So I'm going to bring the discussion to a close and then leave 5 minutes for open questions and answers. So let me get back to the screen here. And okay. So Harish covered very eloquently the clinical reasoning in the OSCE setting. And I just want to talk about workplace, in the clinical workplace strategies. And the stop-start method was already brought up more than once. This can be applied in OSCE, but much more natural in the workplace setting. So, but then one of the biggest challenges here is when somebody is presenting a patient to us, to the clinical supervisor, stopping them can just make them disoriented. Where am I going next? So some orientation ahead of time is really important for this. And the next is the SNAPS method. Now the SNAPS method was actually written up or designed by the Wolpaws, who used to be at Case Western. They're now at Penn State University, Terry and Dan Wolpaw. And this is more for the students to learn in presenting a patient in a very systematic way, but in brief. So micro skills is what the teachers use to assess clinical reasoning. And I'll talk to you about snaps in a second, micro skills is what teachers use to test, assess, and it really came out of the 1 minute preceptor. So it's not just, okay, make a diagnostic commitment and then probe for underlying reasoning. And the teacher's role is, and that's the clinical reasoning. So what is your diagnosis, or what is your differential diagnosis? Probe for underlying reason. Why do you think that? And then some teaching general rules, which is, okay, if this were a patient, 65-year-old with chest pain versus 25-year-old who presents with chest pain, what's the difference? So general rules. And then reinforce the last two are feedback, which is tell them what they did right and correct gently. So that's the micro skills. But more importantly, in the real life clinical setting, when teaching, clinical supervisors need to make thinking explicit. So this is my diagnosis. Quite frequently, all of us can be blamed for this. We just say, oh yeah, this is the diagnosis. But we just don't stop and think out loud and say, how did we reach this diagnosis? Push the learner to consider the why rather than the what. And the same questions which we reported from group 2 can be used in the real life setting. And consider the use of what if. So what if this were a different kind of a patient or different kind of a presentation? Would your differential diagnosis change? So last thing, we'll just conclude this is the didactic part or the summarizing part with how can clinical reasoning go wrong? And this is not something that we need to know. We don't need to name all the cognitive biases on the face of the planet, but just be aware that cognitive biases exist within us and within our learners, and just recognize them. We keep on talking about cognitive biases at premature closure. That is only one of various cognitive biases. So people can, oh, I saw this patient with chest pain last week. Therefore, today that's the same diagnosis, recency bias. And I think this is this diagnosis. So fit in all the historical and clinical exam, the physical exam details to fulfill your diagnostic plan or diagnostic hypothesis rather than actually analyzing or performing systems to thinking. And so we need to be self-aware. Harish talked about the metacognition. So how it's not only what we think, but how do we think? Not what we learn or what we know, but how do we learn it? So we need to be able to understand that there are cognitive biases, and we need as teachers to recognize those cognitive biases and then learn how to intervene, which also means that we need to recognize our own cognitive biases. So these are many cognitive biases, which you have actually a few. There are even more in the literature, but this is there in your handout. The premature closure is what is anchoring, focus on a single feature, and then forget everything else. Availability bias is, okay, I remember these are the 3 differentials that come to mind, so let me fit the clinical picture into these that I know already. Framing, how is the problem presented? Something can be, patient comes from the emergency room and you don't, you carry on that same diagnostic plan without necessarily gathering new data. Affective bias, emotional fatigue, feelings towards patients. So there's this unconscious bias. Overconfidence, I know this, therefore this is the diagnosis. Blind obedience, my attending said this, therefore this is the diagnosis. So these are a few, and there are many more that exist. And let me stop sharing and just open it up to.
We have time for one question or 2 short ones, if anyone has one. All right, I'm going to ask one of Harish, though. Harish, can you comment on a little bit on assessment of clinical reasoning or facilitating clinical reasoning? So they're different, but also, if you will, in the learner, time to think. And where I'm going with this is, I think the more junior the learner, sometimes giving them time to kind of process it themselves before they speak it out loud can be of benefit. But how do you kind of balance that? Because certainly for efficiency in the clinical world, we ask them in the moment, on the spot. tell us what you're thinking.
Yeah, I agree. I mean, my main work is with undergraduate learners, as I mentioned, and so we would potentially debrief a case live in the observed scenario over 40 minutes. So my consultations are normally 10 minutes in primary care, and we have to take it slow to give them time so they don't feel threatened by what's going on. As soon as they feel threatened, their learning willingness goes down. But we do then start to expect our graduating cohort in year 5 to be much more efficient in terms of reasoning strategies, and we expect them to be quicker at identifying differentials and to be able to justify and prioritize. Within a few months, they will be released into the real clinical world. So yeah, I think you're right, Eric. This needs to be matched to the stage of learner that you have.
That makes sense. Any last thoughts? Last quick question while we have such a fun group here together.
Well, I would just thank Yoon Soo for pointing us to a couple of resources in the chat. If you haven't had a chance, click those links. 2 great papers he sent over.
With that,
Eric,
it's so
just
fun.
quick,
Go ahead, Ed. Yep.
just a quick comment on yours and Harish's comments, and that is, isn't it ironic that what we want them to do is to be able to get to the point that they can answer quickly, but that's typically a system 1 kind of response, when in fact our goal is to get them to be more thoughtful and to be able to operate quickly in system 2. And then the question is that an oxymoron?
I think that's a perfect one to end with. With that, I just want to say how fun it is to get everyone together across the globe. It's so late or early for so many of you, but we really appreciate it. We look forward to doing this again as your schedule allows. Wishes everyone here a happy holidays and safety. There's a vaccine ahead, so hopefully we're all headed that direction. Great to see everyone.
Thanks, Harish.
Thank
Thanks,
you.
everyone, for attending. Until next time.